right. Hi, everyone. Thank you for the invitation to speak with you today. I am a pediatric neurologist just a couple miles from here in Oakland and also at UCSF in San Francisco. And full disclosure, I'm not a GM1 expert. I have seen a few children with GM1 through trials and am involved in clinical trials, many of the trials that have been mentioned earlier today. But my goal with you this afternoon is just to talk through how I, as a neurologist, might approach a first visit with a child with GM1, the things that I would be looking out for, the things where I know I can potentially intervene and make a difference. But with all that said, it's really important for me to hear from the parents and what your concerns are and to kind of build a plan together. So this is a starting point for a visit, but really, I see a first visit and then the subsequent care as a collaboration between what I can offer and what a parent's primary concerns are. And so I'm not going to go in depth into the natural history of GM1, but it is important in terms of framing the discussion today of just kind of knowing what the core neurological features are for a child with earlier onset and later onset. So, earlier onset, we're going to be worried about things like hypotonia, low muscle tone, spasticity, seizures, and then as we move into the later onset forms, particularly the type 3, we're going to be looking at dystonia and extrapyramidal symptoms, so involuntary movements of a different kind than we see in the early onset forms. And another framework for a neurologist to think about treating a disease like GM1 is to understand what parts of the brain are affected and which type of the disease or which phase of the disease we're in. And so in the early onset, we know that the thalami are involved. Those are the bright areas on the left panel there and the darker areas in the center of the brain. Just to the right of it, the thalamus is this critical relay station for taking in sensory input from the environment and integrating it into motor outputs and language and communication. And so when that's affected early, as you can imagine, it manifests with all kinds of psychomotor challenges for affected children. And then due to the progressive nature of GM1 with the early onset, the panels on the bottom there from C to D, you can see what happens over 3.5 years. That's the time elapsed between those two scans, and there's a dramatic amount of brain atrophy that occurs during that time. And so that correlates with the loss of milestones that occurs early in the disease course. And then over on the right is a later onset, an MRI scan of a patient with later onset GM1, which looks completely different. And there are these more subtle findings that can be picked up, those bright areas in the putamen, and then the darker areas in the globus pallidus to the far right. And injuries to those parts of the brain correlate with the movement disorders that we see in later onset GM1, the dystonia and extrapyramidal symptoms and Parkinsonism. So with that background, the 4 main topics I'm going to cover today briefly are hypotonia, dystonia, spasticity, and seizures. And hypotonia is one of the first manifestations of infantile onset GM1, and it's different from weakness. They often go together, but they are separable phenomena. So weakness is a reduction in the force that a muscle or a group of muscles can generate. And so I think that's a pretty obvious term in many ways, that you just, sometimes you can't overcome gravity because of muscle weakness, whereas hypotonia is more of a reduced resistance to passive movement. So the limbs can feel very loose and kind of hypermobile, almost floppy. And that may also manifest in a loss of postural tone, so difficulties sitting up, standing, maintaining a certain position for long periods of time. And there are different patterns that I look for as a neurologist to tell me whether hypotonia is coming from a central nervous system problem in the brain or spinal cord, or a peripheral nervous system problem in the nerves and muscles. And so in the central nervous system, we often see this combination of low postural tone, so a child who's having difficulty sitting up or standing, but then may have increased tone in the arms and the legs. And I'll get to some of the types of increased tone in a little bit. But when you see that kind of mixed picture, that points to a problem in the central nervous system. Whereas in the peripheral nervous system disorders, which is a lot of what I see in my own clinical work with muscular dystrophies and nerve diseases like spinal muscular atrophy, there tends to be a hypotonia throughout the body that is accompanied by severe weakness. And so these are kind of two different patterns. Of course, GM1 would fit more into the central nervous system pattern of this combined hypotonia and increased tone. So what does hypotonia look and feel like? So when you're lifting up a baby with hypotonia, they may kind of slip through your hands. They can't hold up their own weight. If you move their limbs around, it may feel like they're almost a rag doll. There's just no resistance to flexing the elbow and flexing the knees and hips. So the limbs feel very loose. And then if you try to pull a child to a seated position from lying down, there may be a lag in their head. They may be unable to sit up due to that loss of postural tone. And then things like crawling, standing, and walking are often delayed or absent as well. But again, hypotonia is not the same as weakness, and children with even quite severe hypotonia, although they may be delayed in their motor development, they can make significant gains in strength, and I've seen this happen many times. So hypotonia does not equal a permanent state of weakness at all. The two can be separated in many cases. So how do we manage hypotonia? Unfortunately, we don't have any medications right now that increase muscle tone throughout the body. And in some ways, when we get to the high muscle tone part of the talk, we'll see that it's not a great idea to try to increase muscle tone too much, because that comes with its own problems. But physical therapy is really the best way to help build postural tone in children. And physical therapists that work with children are quite experienced working on hypotonia and how to get a child to start building some head control and trunk control and building muscle strength in the limbs as well. Another important point is to make sure that we're not doing anything that is actually exacerbating the hypotonia. So many of the medications that we use for central nervous system symptoms, like treating seizures or high muscle tone, or helping with sleep even, can exacerbate hypotonia and make a child more floppy and loose and kind of add to their challenges of making progress with their motor development. So we want to make sure there aren't any medications that are working against us. And then again, important to remember that even if hypotonia remains, strength can grow. And so that's often what happens with physical therapy, is that the muscle tone may remain very loose, but a child can still start to make some progress with motor developmental milestones like sitting up and standing. So now moving to the other end of the muscle tone spectrum is spasticity. So spasticity is an increased muscle tone or rigidity. And it's more specifically defined as an increased resistance to passive movement. So if you move a child's arms and legs through their kind of passive range of motion, what you may feel at some point is some resistance. So it's just hard to move through that range, or there may even be a catch where the faster you go, the muscle may catch at a certain point, and the resistance builds to that point. And this catch is called a spastic catch, and it translates into a lot of difficulty with voluntary movements for a child who has spasticity. And the most frequently affected muscle groups in the legs are going to be the hip adductors, so the muscles that bring the hips together, and then also the ankles. And so the tight ankles are very frequent in children with spasticity. And then in the arms, it tends to be flexion at the elbows, wrists, and fingers that we see with spasticity. The most common situation we see this as neurologists is in children with cerebral palsy, which comes in different varieties. So there's hemiplegic, which affects half of the body, the spastic diplegic. Spastic diplegia affects only the legs, and then spastic quadriplegic cerebral palsy affects the arms and the legs. And so I bring up cerebral palsy because children with GM1 and similar disorders are often diagnosed with cerebral palsy first before it's really clear what's going on. And I think some of that time lapse that happens between symptom onset and definitive diagnosis, often cerebral palsy is kind of the working diagnosis at that time. And it's a useful framework because there are ways that we can treat children with spastic cerebral palsy that would apply to children with GM1. At the same time, you don't want to stay in that diagnostic category for too long if it's not the most precise or accurate diagnosis. And given all the developing therapies for GM1 and other related conditions, it's critical that we not ever stop at a diagnosis of cerebral palsy and say, that's it, that's what's going on with this child. We need to push further, and increasingly we're testing children who are diagnosed with cerebral palsy with genetic testing and finding that no, they don't, that's not the most accurate diagnosis for them. There is a lysosomal storage disorder or something similar that may take us off in a different therapeutic path. So spasticity, our treatments involve ways of reducing muscle tone, either globally or more focally. So the kind of blunt tools would be the oral medications, things like baclofen and benzodiazepine medications that are muscle relaxants like clonazepam and Valium and dantrolene. And then for more focal spasticity, for example, if you just want to relax the ankles or the hip adductors, Botox injections can be very helpful, although they only last for a couple months at a time. It's possible to deliver baclofen through a pump that delivers it to the spinal fluid. And that's a way of reducing some of the side effects that come with high doses of oral baclofen. There are a number of orthopedic approaches to reduce muscle tone that include orthotics and casting and surgeries to affect the muscle length. And then finally, there's selective dorsal rhizotomy, which is a spinal surgery done by a neurosurgeon where they cut specific sensory nerve roots in the lumbosacral spinal area to reduce the muscle tone to certain muscle groups in the legs. So another form of increased muscle tone is dystonia, and it looks very different from spasticity. It has more of a fluctuating character typically. So there may be more sustained movements, but often they're kind of on and off periods. It can be either focal or generalized. Some of the common muscle groups that are affected include the neck, as you can see in panel C on the slide, or a writer's dystonia as in A, dystonia at the ankle as in B, or kind of a truncal dystonia as in panel D. And dystonia is often very state dependent. So in a relaxed state, you may not see it at all, but as a child gets stimulated or you ask them to perform a voluntary movement, even something like just reaching for an object, you may start to see that dystonia coming out. And I don't know if it's possible to play the video. I'm not able to click on there we go. So this is an example of a child with dystonic movements. This is not a child with GM1, but this is a genetic, he has a genetic form of dystonia. And you can see that his limbs are kind of twisted, and he has difficulty maintaining postures and performing voluntary movements. And so you can see he's trying to write here with his right hand, but there are all these overflow movements of his left arm and his head and neck, and makes writing and performing those kind of routine home and school activities very challenging. And you can see that walking is also, he can walk, but there are these overflow movements to his head, neck, and left arm. And next slide. So the treatment of dystonia, it does overlap somewhat with spasticity. So there are oral medications like we can use baclofen, Valium, some medications that are used in Parkinson's disease like levodopa, carbidopa. Botox can be highly effective for focal dystonia, for example, if it's primarily affecting the neck or wrist, for example, but not so helpful if it's generalized dystonia affecting all parts of the body. And then deep brain stimulation is kind of a more recently emerging treatment for dystonia. It historically has been used primarily for adults with Parkinson's disease and tremor, but we're now moving it into children with cerebral palsy and children with genetic dystonias. And so this would apply mostly to our later onset GM1 patients. And so it's the same video on the left. If we could play the video on the right, this is just the results of deep brain stimulation in this child afterwards. So, this is a remarkably good outcome. Not every child who undergoes deep brain stimulation responds this well, but it is an example of how this technology that started out for adults with Parkinson's is really profoundly impacting some children with dystonia. And it does require a implantation of a stimulator into the basal ganglia in the brain. So it's a complex brain surgery, and there's some hardware that remains. It can certainly be taken out later if the device isn't effective or there are some complications, but it's not something to be approached lightly, and usually we want to exhaust other options before we go to deep brain stimulation, but in certain cases it can be life-changing. And that's now one of the treatments that we're offering in our cerebral palsy center for children who kind of have a brain structure where there's a good target for the deep brain stimulator to be placed. And then there are also ablation approaches where we basically surgically or with ultrasound create a lesion in the part of the brain that is driving the dystonia. This is done less often now just because it requires a destructive process for the brain tissue, and we'd rather avoid that if we can. And finally, I want to talk about seizures briefly. So seizures and GM1 gangliosidosis are primarily going to occur in the early onset group. These can take various manifestations. They can be generalized, affecting the whole body, either with stiffening or shaking. They can be focal, affecting just one part of the body. They can involve brief losses of consciousness, just lasting a few seconds. These are called absence seizures. And then myoclonic seizures are common in GM1 and involve jerking, usually single jerking movements of a limb. And seizure management has evolved quite a bit over the past few decades. There was a rather limited toolkit even 20 years ago, but there's now many, many more medications available, and even new medications that have come onto the market that are helping children who haven't responded to any of the first 5 or 6 medications they've tried. So I think we're really fortunate to have a lot of tools available. And so if there are side effects with the first 1, 2, 3 medications, there's still hope for finding something that can bring the seizures under control. The first stop is always oral medications. And so some of you may be familiar with medications like Keppra or Depakote or Onfi. These are often the ones we start off with. And then some of these newer classes of medications like cannabidiol have been quite effective for children with refractory epilepsy. And there's been a lot of buzz about cannabidiol in particular. When multiple medications have failed to bring seizures under control, the ketogenic diet is an option. This is a high fat and protein, low carbohydrate diet. It's very challenging to follow, so it's not just kind of changing the stuff that you buy at the grocery store and finding some new recipes. It is a complete shift in the types of foods that one can eat, and it has to be followed strictly or it doesn't work. But it is a great option for some children and can bring refractory seizures under control in some cases. And then vagal nerve stimulator and surgery to remove a focus of epilepsy from the brain are also options further down the line if none of the medications or ketogenic diet work. And so the main testing we use in epilepsy is the EEG or electroencephalogram, and there are two main types of EEG that we do. One, you do in an outpatient office for 30 to 60 minutes, and this looks at background brain activity and can help us assess seizure risk, but usually we're not going to actually observe a seizure during that brief amount of time. If the goal is to try to capture an event that might be a seizure and determine definitively if it is a seizure and what type, that's best done with an overnight EEG, which can be done over a single night or multiple nights. And the goal there is to actually capture an episode, determine if it's a seizure. We can look at some seizure types tend to come on during sleep or as a child is emerging from sleep, and this is the best test for catching those. And then we can also use EEG if we want to kind of rapidly try out a new medication to try to bring the seizures under control and improve the EEG pattern. That can be done during an overnight EEG. And then finally, anesthesia and GM1. If you look this up in the literature, there's a single paper that comes up, and it's I don't think it's a paper that we can extrapolate to every child from. I think I would say in general for children with complex conditions like GM1, especially with with airways that most may pose some challenges for the anesthesiologist, it is best to go to a center that has some familiarity working with kids with complex airways. So as an example, at Children's Oakland, we have a single anesthesiologist who does all the anesthesia for kids with MPS, and he also does the sedations for kids with GM1 in our trial. And so we try to make sure that every child with a complex airway is managed by someone who's familiar with the complications that can come up. And in general, I think it's best to really ask before any sedated procedure, is this necessary? Can we wait and combine this with any other surgeries or other sedated procedures so that a child is not being repeatedly put under anesthesia, because there are risks with each anesthesia event, and in general, more anesthesia events, there can be some cumulative impact on development over time as well. And so I think anesthesia, can it be done safely in children with GM1? Yes, but it's not to be taken lightly, and there should be some thoughtful consideration of who's going to be the anesthesiologist, and can we lump together several procedures so that there's a single anesthesia event in a year rather than 3 or 4. And so just to summarize, GM1 causes a spectrum of neurological symptoms from the early onset to the later onset that include low muscle tone and different types of increased muscle tone like spasticity and dystonia. There are many treatments available for both of these, from oral medications all the way to surgical options. And children with GM1 should be working with all the available therapists that they can to help promote their development and muscle mobility, stretching, things like that. And then for seizure management, there are again many options, and the list of options is growing over time. And so don't feel discouraged. Don't give up hope if the first couple medications don't control the seizures. There are lots of options further on down the line. And then I also want to highlight that with all the therapies we're hearing about today, we may eventually see a point where children with early onset disease have an improvement and are manifesting some of the symptoms we see in later onset disease. And so the treatments for dystonia, like deep brain stimulation, which so far has only been tried in, well, there's one report of a child with GM1 treated with deep brain stimulation, or I think it was a young adult actually. But that may be an increasingly useful option. After gene therapy, maybe there's some disease stabilization, but we start to see those later onset GM1 manifestations. It's going to be important for the neurologist caring for these patients to recognize that that there's many options available for dystonia treatment. So I will end there and take questions at the end of the session. Thank you.